If you meet a patient who has survived critical illness several months after they're discharged from the ICU, it is staggering how much weight they tend to have lost and how exhausted they say they're feeling all the time. And there is a reason for this. It's because of metabolic dysregulation during critical illness. To understand our strategies for feeding and rehabilitating patients who are critically ill, you need to know what happens at the time that the patient becomes acutely critically ill. Key concepts in critical care with me, your host, Pat Nelly. This tutorial looks at metabolism in critical illness, and I'm going to coin a term here, and that term is critical illness cachexia, to describe what happens in our chronically critically ill patients in terms of metabolism and the state of their bodies. Let's start with a clinical scenario. It's Monday, and you are rounding in the ICU, having not been there in weeks. And you come to a patient, Larry, who has been in the ICU for 18 days. Larry came in 18 days ago when you were the doctor in the ICU. When it's me, one of the first things I do when I look at this type of patient that I haven't seen in quite some time is I pull back the sheets to have a look at their legs. And you can see that this patient has tremendous loss of quadriceps muscle mass. Sometimes it's not as obvious. For example, this may be a patient that you see in the ICU. This is an AI-generated image. And the patient looks okay, but in fact, he had looked like this several weeks earlier. What follows are the reasons why patients lose a considerable amount of their body mass right in front of us on a daily basis, despite our best efforts. So in this tutorial, I'm going to discuss why critically ill patients lose so much weight, nutritional requirements in normal people, the stress response to critical illness, how the phases of the stress response impact metabolism, hypercatabolism of proteins and autocannibalization, in other words, critical illness cachexia, and things that we may or may not be able to do about it. Let's start with normal metabolism. Our daily nutritional requirements are based on an internal thermostat that's known as the basal metabolic rate, and that controls the total body mass that a person has. And that's one of the reasons why it's very hard to actually lose weight if you are overweight or obese, because the body keeps manipulating its basal metabolic rate to keep the body mass where it started. There are a whole variety of other homeostatic mechanisms involved in this. But in general, one requires about 30 kilocalories per kilo per day of total energy. Of that, 1 to 1.5 grams per kilo per day of protein is required, 1 to 1.5 grams per kilo per day of fat is required. And in general, for most of us, the remainder of the energy that we consume is in the form of carbohydrates. But carbohydrates are not essential in the human diet. In fact, for the majority of the history of mankind and womankind, carbohydrates were not available all year round. Perhaps there were berries or fruits or vegetables available in the summer or the autumn. But through the winter and spring, we didn't really have lots of carbohydrates to consume. And so we are able to utilize protein in particular as a way of generating glucose. And that's a critical thing to understand in critical illness. The body also needs 30 mils per kilo per day of water. But be aware that half of that is in food, meat, vegetables, fruits. They're full of water. And I have a bit of an issue with this because virtually all so-called health gurus recommend the consumption of vast quantities of water per day. You see people going around carrying these huge receptacles of water and swigging from them all day long. There is a significant problem with this because in order to dilute the urine to get rid of all this surplus water, a lot of osmoles that are derived from protein catabolism are required. Otherwise, patients will develop symptomatic hyponatremia. And every couple of weeks, we see somebody being admitted to one of our units with profound hyponatremia from excess water consumption. So in summary, the reason why we need these different macromolecules is that we use protein to build muscle, that's lean body mass and viscera, including the heart and the diaphragm, fat is used to build cell membranes and nerves, and glucose is an obligate energy source in the body. It's the only source of energy that red cells can use. There are no mitochondria in red cells. Remember, you need your red cells to deliver oxygen to the tissues and pick up carbon dioxide. Also, it's the principal energy source of the heart and the brain in normal circumstances. With adaptation, the heart and the brain can use other sources, particularly ketones, but normally glucose is the main source of energy. So carbohydrates are ultimately metabolized to make glucose. Proteins are metabolized to make amino acids, but they can also be metabolized back to glucose, as I'll explain in a few minutes. And fats are metabolized to free fatty acids. The major goal of the body's metabolism, though, is to keep the blood glucose within 4 and 5.5 millimoles per litre, or 70 to 100 milligrams per deciliter. Without that glucose, the body cannot function. And that metabolism is controlled principally by insulin secreted by the pancreas and the liver. Dietary proteins are metabolized to amino acids, dietary carbohydrates to glucose and subsequently lactate and pyruvate, and dietary fats are metabolized to free fatty acids. Both carbohydrate and fat metabolism then enters the same metabolic pathway, the Krebs cycle, where oxidative metabolism occurs and ATP and carbon dioxide are generated. This is a very simple cartoon to reflect body mass. If the entire object reflects the whole body, yellow represents fat body mass and red represents lean body mass. The insulin levels are normal and they change with diurnal variations depending on when food is ingested. If one goes on a calorie-restricted diet, there is a loss of all forms of body mass, but fat body mass is lost in higher proportion to lean body mass. And the reason for this is that fat is seen by the body in normal states as a form of energy reserve. Lean body mass is lost to a certain extent because the frame becomes smaller, so less muscle is needed to carry it around. But because the body is in a state of catabolism, more calories are being burned than ingested. Insulin levels are relatively low. In starvation, once fat body mass is lost, then lean body mass and visceral protein is mobilized to generate energy. And in this state, insulin levels are very low. Let's look at this in slightly more detail. In starvation, we call on our reserves. There is no food intake. Hence, the body must auto-cannibalize. Muscular protein is broken down to amino acids, glycogen, and other sources are utilized to generate glucose, and fat is broken down to free fatty acids. Glycogenic amino acids, lactate, pyruvate, and components of the Krebs cycle are sent to the liver, where they undergo gluconeogenesis in order to keep blood glucose within normal limits. Remember, this glucose is needed for tissues that are obligate glucose users, principally red blood cells. However, most of the energy that the body uses is derived from the free fatty acids that come from adipose tissue and associated compounds. In the liver, free fatty acids undergo beta hydroxidation to form acetyl coenzyme A, and ketogenic amino acids such as leucine and lysine can also be metabolized to acetyl coenzyme A. This is then converted via a complex web of intermediaries into ketone bodies, principally acetoacetate and beta hydroxybutyrate, and they are then exported from the liver to most of the body organs where they're used as a primary source of energy. Now let's go back and have a look at Larry. 18 days ago, Larry, a 64-year-old plumber, cut his hand on a rusty pipe. He licked it, and that night his hand started throbbing. The next morning, the sheets of his bed were saturated, and Larry started hallucinating. He went into the emergency department, and at that stage, he was tachypnic, tachycardic, hypotensive, and in respiratory distress. What was going on with Larry is that he was undergoing a stress response to acute critical illness, in this case sepsis. The stress response, as I'm about to describe, is a normal adaptive reaction that the body makes to tissue injury or surgery. It is entirely reproducible and it occurs in all patients that undergo such injuries. There are three components to the stress response: an immune reaction, both to supercharge the inflammatory cells and to fight pathogens and increase oxygen and nutrient delivery, derived from a period of hypermetabolism, all guided by changes in the neuroendocrine system driven principally by an increase in circulating cortisol, adrenaline, epinephrine, noradrenaline, norepinephrine, and glucagon, and there is relative hypoinsulinemia. Catherine is a 48-year-old teacher, and while walking in the schoolyard on an icy morning, she slips, trips, and falls. She has severe pain in her left hip and has a fractured neck of femur. Immediately after the injury, the body goes into a state of shock. This is a teleological response that the body undergoes as part of the fight or flight reflex, because during the course of our evolutionary history, the major impact of injury has been blood loss. So the body shuts down blood flow to the extremities to preserve the brain and the heart, and this process is driven by the adrenal gland. Cortisol is released, and acting as a cofactor for epinephrine, adrenaline, and norepinephrine, noradrenaline, it causes intense vaso and venoconstriction, reducing the unstressed blood volume and pumping blood back to the heart. There is reduced renal blood flow, and that activates the renin-angiotensin-aldosterone axis. An increased plasma osmolality causes increased release of vasopressin, and this has an anti-diuretic effect, and it also supports the hemodynamic effects of catecholamines. I'm going to draw a simple graphic cartoon with an X and Y axis. On the X-axis, we have time that can go on for hours, days, or months. On the Y-axis, we have energy expenditure. That is the number of calories consumed by the body at that point in time. The intersection of the X and the Y-axis is the normal level, what you and I are doing now. Above that line, the energy expenditure increases, and below that line, it decreases. Immediately after the injury, Catherine's basal metabolic rate falls, and this is known as the ebb phase of the stress response as originally described by Cuthbertson and Moore, and it is associated with a fall in the temperature and sympathetically induced diaphoresis and oliguria. So the ebb phase is the classic hyperadrenergic shock picture that you might see, for example, in a patient who has had a myocardial infarct. A few hours later, or after fluids or opioids are given, the situation changes. The hyperadrenergic activity persists, but there is now widespread activation of the inflammatory response with release of inflammatory mediators and vasodilator metabolites. We will drop the axis down because everything goes upwards now. I'm going to draw two more lines, one at 48 hours and one at 72 hours. And we are going to assume that Catherine does not require surgery. Energy expenditure increases, and this peaks at 48 hours, eventually drifting down to a level just above baseline at 72 hours. This is the flow phase of the stress response. It's characterized by stress hyperglycemia driven by catecholamines, glucagon, and insulin resistance. There are an increase in inflammatory mediators, interleukin-6, procalcitonin, and C-reactive protein in that order. A hyperdynamic state where blood pressure becomes soft, the heart rate increases, as does cardiac output. Urinary output falls and the body weight increases due to a positive fluid balance, often associated with IV fluid administration. So the flow phase is the classic inflammatory picture that we are used to seeing in perioperative and critical care patients. It's a normal host response. Now let's stretch the timeline out to 7 days. From The 72-hour point onwards, assuming that there are no medical or surgical complications, the stress response burns itself out, and we call this the recovery phase. Blood glucose falls, and that falls down towards normal. The CRP gradually reduces, heart rate and blood pressure normalize. There is a brisk diuresis. Often the patient will require potassium, phosphorus, magnesium, sometimes calcium, and the body water content returns to normal. So this is our standard adaptive stress response, and you yourself likely had one at some stage in your life. It occurs with trauma, with infection, surgery, burns, etc. But this is not the stress response that Larry had, because Larry has an inadequately controlled soft tissue infection, and he developed systemic sepsis. He has septic shock with impending multi-organ failure. Larry is acutely critically ill. In the setting of acute critical illness where the source has not been rapidly controlled, in a certain subset of patients, the stress response becomes haywire. It becomes maladaptive, and the response hurts the patient. In critical illness, the flow phase persists alongside inflammation. So this is our standard adaptive stress response. I'm going to zoom out the timeline here. We have our injury at the very beginning, and then we're going to look at 4 days, 10 days, and 18 days. That's today in Larry's care. Now let's look at purely the inflammatory activity in this timescale. Larry is injured and he's a short ebb phase, and this is followed by an enormous inflammatory response that persists for 6 days. So we have a really long flow phase that uses up a tremendous amount of inflammatory reserve. This is progressively lost, but fortunately the infection is under control, and then later that reserve starts to build back up. So we have 4 phases: an ebb phase, a flow phase, a dysfunctional flow phase, and recovery. In the original flow phase, there was systemic inflammation. In the prolonged flow phase, there is hypoinflammation, and the patient is a sitting duck for secondary infections. And then in the recovery phase, inflammatory reserve is restored. Now let's look at energy expenditure, which is the major focus of this tutorial. Again, we have our injury and the ebb and flow phases. Notice that this hypermetabolic state has gone on for days longer than the normal stress response. Subsequently, all the way up to present, metabolic activity remains above basal metabolic rate, and that still persists into the recovery period. The little spikes that you see during the dysfunctional flow phase correspond to fevers and increased overall metabolic activity. I want to look at substrate consumption at each stage of the dysfunctional stress response, and this is simplified, and I'll go into more detail a little bit later on. During flow and chronic critical illness, there is dramatic tissue catabolism, but anabolic activity gradually returns, and there is an arms race between nutrients rebuilding tissues and various mechanisms breaking them down to support inflammation and tissue healing. In the ebb phase, carbohydrates are utilized and hepatic glycogen is drawn upon and then exhausted, and subsequently skeletal muscle is mobilized for gluconeogenesis and ketogenesis to provide substrate for normal glycemia. Once the source has been controlled, the stress response abates and fat utilization takes over, and it becomes the dominant source of energy consumption. The patient develops a state of marasmus-like dysnutrition, such as what we see in Larry's case. Eventually, anabolism wins over and everything settles down. Although I really like to know the patient's body weight in critical illness, due to fluid retention in acute critical illness, body weight may actually rise. And once deresuscitation has taken place, clinicians routinely overvalue the premorbid weight due to an underestimation of loss of lean body mass. As fat loss is late in the process, combined with edema, the patient often looks less malnourished than they actually are. Now let's look at body mass in critical illness. Larry has septic shock with systemic hyperinflammation due to soft tissue infection. He was resuscitated with 5 liters of sodium lactate solution, that's lactated ringers or Hartmann solution. He's given vasopressors, undergoes debridement in the operating room, and post-op he's intubated in the ICU. Early in his critical care stay, he's on 60 mics per minute of norepinephrine and vasopressin 0.3 units per minute. When you see patients on industrial doses of vasopressors, you must keep asking the surgeons whether or not they've actually achieved source control. Of note, an NG tube was placed in this patient at this stage and trophic feeds, that's 20 mL per hour, were started. I'll get back to the feeding strategy in the follow-up tutorial. Inflammatory tissue needs glucose, and lots of it. It is driven to the site of injury by the cardiovascular system and the red blood cells, and the heart and the red blood cells need glucose. So there is a dramatic increase in the need for glucose in a hyperinflammatory state. Let's return to our baseline situation of fat and lean body mass. In acute critical illness, body weight does not change or may increase due to fluid accumulation, but lean body mass is lost. Fat body mass is essentially unchanged, and catabolism of skeletal muscle occurs despite very high levels of circulating insulin. What happens to all this substrate? Let's have a look at the specific substrates that are utilized in acute critical illness. Our bodies always use carbohydrates, proteins, and fats for energy in health and disease. In the stress response and in critical illness, the relative ratios vary depending on what the timeline is in the patient's physiology. The early phase is dominated by carbohydrate metabolism, but that rapidly depletes glycogen stores, so by the time the flow phase starts, much of that energy is derived from muscular protein and fat. You will note this dramatic increase in energy expenditure in this flow phase of the stress response. Subsequently, by far the majority of energy expenditure is derived from both protein and fat, and carbohydrate utilization reduces significantly. Let's look at the various substrates, starting with carbohydrates. In the ebb phase, we have glycogenolysis and rapid depletion of glycogen reserves. The flow phase is characterized by sustained gluconeogenesis with mild hyperglycemia that is not suppressed by exogenous glucose, in other words, glucose infusions. There is significant insulin resistance. In the stress response and in critical illness, insulin resistance is an adaptive mechanism. The response prioritizes hepatic glucose production, gluconeogenesis, and the supply of glucose to vital organs, and it also prevents peripheral uptake of glucose to fat and muscle due to downregulation of the GLUT4 receptor in muscle and fat. In the catabolic phase of the stress response, a variety of glycogenic amino acids are liberated from skeletal muscle and travel to the liver, where they undergo gluconeogenesis. This produces glucose, and that is utilized by red blood cells, the heart, and the brain. Remember, these are vital organs. The glucose is needed there and not in the muscles and fat. Normally, when blood glucose rises, insulin is secreted, and that pushes glucose into muscle and particularly into fat, and gluconeogenesis is suppressed. But due to hormonal competition and downregulation of receptors, this effect is counteracted, thus saving glucose up for the tissues where it is needed. Finally, muscle must get its energy from somewhere, and that is principally from fat, either free fatty acids or ketones. So we move on to lipid metabolism in critical illness. Because the stress response is driven by adrenaline or epinephrine and other catecholamines mediated by inflammation and beta-2 receptor activation, there is a marked increase in lipolytic activity in peripheral tissues and a dramatic increase in triglycerides and free fatty acids that are released into the blood. While this is used as a major source of fuel, particularly by the heart, it is interesting that the release of free fatty acids and their production from triglycerides and chylomicrons continues even if exogenous lipids or carbohydrates have been administered. In the setting of insulin resistance, glucose is not taken up by skeletal muscle cells. Free fatty acids instead are the major source of energy. Early in acute critical illness, there are increased plasma free fatty acid levels. It is believed that this is a teleological response. The fat is used to bind endotoxin and other bacterial pathogens, a bit like how we use intralipid for binding local anesthetic and local anesthetic systemic toxicity. And the free fatty acids are not a major energy source in that very early phase of critical illness. Remember, the tissues are using protein and carbohydrates. And so those lipids are cyclically broken down and re-esterified in the liver. As critical illness or the stress response progresses, peripheral utilization of free fatty acids increases, assuming that the mitochondria are working, as does ketone production in the liver. This may ultimately result in steatosis, that's a fatty liver, and steatohepatitis, alongside dysfunctional bile acid transport activity. This manifests as a mild hepatic enzyme leak on your blood tests and a high bilirubin, and that's a component of the SOFA score, that's the sequential organ failure assessment score. Cholesterol and lipoprotein levels fall. A core component of why all this glucose is needed revolves around oxygen. Oxygen is used as a toxic agent in sepsis. It is delivered to inflammatory tissue from where reactive oxygen species are generated that act as ordnance in the destruction of pathogens. This has been termed the respiratory burst. And to deliver oxygen to leukocytes, red cells must be fully charged with glucose. Both glucose and oxygen consumption increases. If oxygen delivery is inadequate, mixed venous oxygen saturation may fall. In my experience, this is quite rare. And due to the rapid turnover of glucose, lactate levels rise proportional to the degree of stress, and this may be termed aerobic glycolysis, although I prefer to think of it as purely evidence of increased glucose and lactate turnover. When critical illness becomes severely maladaptive, then there is lots of collateral host cell damage, particularly from reactive oxygen species. There is damage to organelles and DNA. Mitochondria become dysfunctional and may hibernate to self-protect, and a state of cytopathic hypoxia may occur, meaning a dysfunction of the Krebs cycle despite normal oxygen delivery. A quick mention of lactate. At times of enormous metabolic demand for both glucose and oxygen, stress hyperlactatemia is absolutely inevitable. That lactate is principally produced by red blood cells. In health, red cells produce about 320 millimoles per day, more than 1/4 of total body production. And this red cell lactate is reconstituted by gluconeogenesis in the liver and sent back to the tissues. It is imperative that you understand that this hyperlactatemia does not represent either a state of under-resuscitation nor inadequate oxygen delivery. It represents stress. What happens to proteins is extraordinarily important, and I've touched on this already. The picture is marked by a huge increase in total body protein catabolism. Initially from muscle, and this persists for weeks, but subsequently from the gut, connective tissue, and the viscera, including the diaphragm and the heart, and ultimately from albumin and globulins. The body will keep breaking down protein to form glucose until it runs out of glucose in this setting. If the source is controlled and inflammation abates, ketosis occurs and the ketones begin to provide the major energy source. As a healthcare provider, you have to be aware of the extraordinary extent of muscle protein lost. This is known as sarcopenia, and just lying in the bed results in a 0.5% loss of muscle mass per day, and that is doubled in critical illness. After 10 days in the ICU, up to 20% of muscle mass is lost, and although this settles subsequently, reduced muscle function and reduced quality of life persists for years. You might think that there is an easy solution to this problem by giving the patient a huge amount of exogenous protein or amino acids intravenously as soon as they become critically ill. Surely this will slow down muscle breakdown, but that is not the case because of the issue of autophagy. Autophagy is a normal homeostatic process that goes on all the time in our bodies. It is about breakdown and regeneration of body tissues, particularly cellular material. It's a crucial process that helps the cells cope with stress and damage. In critical illness, there is pronounced cell damage, and that may lead to multi-organ failure. Autophagy's role is to mop up the damaged organelles and molecules and reprocess them for energy or enhance excretion, but it becomes dysfunctional in a subset of critically ill patients. Further, we learned from the EPINIC trial that giving the patient amino acids early actually suppresses autophagy, and that results in catastrophic accumulation of metabolic junk products and cellular debris that poisons the body, delaying recovery and increasing the risk of infection. Although there has been for decades huge and apparently logical enthusiasm for early enteral feeding, at least in low-dose, so-called trophic feeds, this ignores the more obvious fact that most people lose their appetites when they become sick. That is a physiological process that all of us are familiar with. The gut develops early dysmotility problems, so food does not progress through the bowel, and diarrhea or constipation may be associated, and this worsens with critical care interventions. The brush border may atrophy, meaning that even though you think you're feeding your patient, you may not be. Indeed, if the bowel is hypoperfused, you may actually induce non-occlusive bowel ischemia. Also, the commensals in the lower GI tract may be obliterated by antibiotics, replaced by more virulent strains that translocate into the bloodstream, causing sepsis. We see this in neutropenia or in patients who have been critically ill for a while, causing second hits. The microbiome becomes a pathobiome. In summary, in early critical illness due to stress and insulin resistance, there is hyperglycemia, and although this glucose is needed for inflammation and oxygen delivery, as the blood becomes progressively sweeter, it provides an excellent culture medium for bacterial proliferation. This is enhanced by endogenous and exogenous catecholamines, sedatives, and loss of bowel integrity. Bowel dysfunction and the tendency for bedside staff to recurrently discontinue enteral feeds prevents achievement of adequate nutrition goals. Protein catabolism rapidly depletes lean body mass and physiological reserve, prolonging immobilization and lengthening the recovery time from critical illness. And this explains why at day 18, Larry has lost such a significant amount of his body mass. But at least while in critical care, he is receiving high-quality nutritional support. He then goes to the ward, sarcopenic with dysnutrition, and this will have a major impact on his recovery and rehabilitation, because even if we are able to manage a decent nutritional and mobilization strategy in the ICU, patients like Larry not infrequently fall off a cliff when they go to the ward because the staff are far less attuned and available to provide the nutritional and mobilization support than the high staff-to-patient ratio that we have in critical care, and this is a strong argument for having post-critical care rehab units. Now, this is an essential paper that all critical care professionals should be aware of. Hermans and colleagues did a 5-year follow-up of patients recruited into a major critical care nutrition trial known as EPINIC. They found that the duration of ICU stay was a direct determinant of functional disability. On the graph, we have a timeline that starts in the ICU, and we're looking at 3 parameters: muscle protein metabolism, muscle mass, and muscle strength. I'm going to draw the homeostasis line. Above this line, the parameters are normal, and below this line, the parameters are altered or reduced. First, let's look at muscle protein metabolism. In the initial phase of critical illness, there is muscle hypercatabolism, and this stops by ICU discharge when anabolic and catabolic activity equalize. However, despite the normal appearance, this was not associated with a rapid return of body mass. That took years, and it gets worse. Those muscles were like the ones that you see on steroid pumping bodybuilders. They look good, but they are really weak, and muscle strength seriously lags behind muscle mass. Hence, patients in follow-up clinics from critical care routinely complain of tiredness and weakness for a prolonged period of time. So, is there anything we can do to curtail this? There are a variety of proposed interventions. The most obvious is feeding the patient either enterally through a tube or intravenously. Enteral feed and probiotics may maintain or restore the gut mucosa and microbiome. Exogenous insulin triggered above a certain glycemic level, such as 10 millimoles per liter, that's 180 milligrams per deciliter, will certainly suppress hyperglycemia and may have both positive and negative effects on metabolism. Beta blockers have been proposed to antagonize the impact of adrenaline or epinephrine in hypercatabolism. Back in the 1990s, we were all really enthusiastic about the use of human growth hormone or anabolic steroids to enhance muscle mass, as we'd all grown up looking at athletes using these agents and cheating at the Olympics or the Tour de France, but they have not proven to be effective. And there's also been a big push for early mobilization and aggressive physio and occupational therapy. You may think that we should, for example, start feeding the patient immediately with TPN. But this is a bad idea. In acute critical illness because of insulin resistance, exogenous nutrients do not suppress hypercatabolism of muscle protein, and the patient may actually be overfed, leading to worse outcomes. If you look at this elegant graph from the journal Critical Care, you will see that the odds ratio of death is on the y-axis of both graphs. On the left panel, delivered calories are on the x-axis and are based on predicted requirements. It's a U shape. Early feeding and late overfeeding were associated with worse outcomes. In the second panel, it is clear that even feeding with protein early in critical illness worsens outcomes, as does later underfeeding. The standard goal of 1.3 grams per kilo per day of protein is inadequate once nutrition has been established. Patients need 2 grams per kilo when they become anabolic. What about beta blockers? A really interesting study in children was published a quarter of a century ago. Critically ill children with burns were randomized to receive propranolol or placebo during critical illness. The beta block children had significantly greater lean body mass at the endpoint of the trial. Surprisingly, to date, these data have not been replicated in a larger randomized controlled trial in adults. There have been a bunch of small trials on the use of probiotics in critical illness. Perhaps they make a difference in terms of ICU-acquired infections. Perhaps this is publication bias. A large randomized controlled trial is required. Overall, what I really want you to understand is that the shorter the duration of ICU stay, the better the physical function. To achieve this, we need to be meticulous in source control, the choice of therapeutic agents, and minimize iatrogenic complications associated with, in particular, fluid overload and oversedation. The key point here is, after 8 days, the patient must be fully fed and mobilized, otherwise critical illness cachexia will occur. I'm a great fan of the concept of the awake and walking ICU that's been heavily promoted in newsletters. To date, though, the only large randomized controlled trial that was of 750 patients in Australia that looked at this subject has disappointingly failed to demonstrate a clear outcome benefit. A systematic review of 15 trials in 11 countries, that was 2,703 patients, revealed that physical function improved at 6 months from early mobilization, but this did not result in a significant improvement in hospital discharge time or a mortality benefit, and there was a significant risk of adverse effects, and that might actually increase 6-month mortality. Food for thought. Let's review this tutorial. In this tutorial, I discussed critical illness cachexia. I discussed the prolonged flow phase in critical illness and how it increases blood glucose, protein catabolism, and fat turnover. Most of the energy for normal body function in that early stage is derived from muscular protein catabolism. Muscle mass and muscle strength when the patient recovers discorrelate. Early mobility enhances strength but doesn't improve outcomes, and feeding strategies need to be tailored to the patient's needs and timing. Next time, I will discuss feeding the critically ill patient, the timing of nutrition, and I'll look at enteral versus parenteral feeding. Join me then, and I guarantee you'll learn something. So that's metabolism in acute critical illness. In the next tutorial, we're going to talk about feeding the critically ill patient, the strategies, and the timing.